Welcome, everyone. We are really thrilled to welcome you all to join our discussion of the characteristic and treatment of Kwashiorkor. The list of attendees is building up, but we will start because we are really expecting to have a lively discussion at the end and keep time for your questions. We wanted to share just a few housekeeping items before we get into the discussion. So the webinar, as you know, is scheduled for 1 hour and we will end on or just before that. We are looking, as I just said, forward to a really lively and engaging discussion. We will not be talking the whole time. So I really encourage you to use the chat function to participate and ask questions as they come to your mind. So if you are not used to WebEx, on the bottom right of your screen, you should see several buttons. And there is one, the white one with the blue chat icon that allows you to then open the chat box on the bottom right of your screen. So when you have this chat box opens, you can then send questions. Please send your questions to me, Alexandra. You can choose to who you send questions and who you communicate with. Send your questions to me and I will gather them for the Q&A at the end of the chat. You will all be muted because we are expecting quite a lot of people, 291 people registered for this webinar. So the only way to communicate with us is through the chat box. If you have any issues, technical issues, you can communicate with Anne or Nola, but any questions should be sent to myself, Alexandra. So just to introduce this webinar, it's part of a series that will revisit the evidence on Kwashiorkor malnutrition. And it's organized by an informal group that communicates and discusses their researches on Kwashiorkor for peer advice. So the way this group was formed, it actually comes from the fact that when I joined Action Against Hunger in 2017, a really great work was done by my predecessor, Jose Luis Alvarez, and also somebody called Nikki Dent, who I think is among the attendees. And this project was called Putting Kwashiorkor on a Map. It was published in 2016, and it was aiming at showing the geographic representation of Kwashiorkor in order to highlight gaps of advocacy and research. So from there, that's how I decided to put a group together of researchers so that we can exchange informally on the researches on Kwashiorkor. But of course, we know that our group is not exhausted. So if you are interested in learning more about this group, please get in touch with me. We will share my contact info at the end of the webinar. And then first, next slide. We are really thrilled to have André Briend as our moderator today for this webinar. Dr. André Briend retired from WHO in 2009 and is now adjunct professor at the University of Tampere and affiliated professor at the University of Copenhagen, Denmark. So I'm turning it over to you, André, to begin.
Can you hear me? Hello?
Very well.
Okay. Thanks, Alexandra. It's a pleasure to be here at this webinar. As Alexandra noted, today we'll focus on the basic characterization and treatment of Kwashiorkor. But before starting the meeting, I would like to show you a few slides. On the first slide, you have the number of publications on Kwashiorkor or oedematous malnutrition by year obtained on PubMed. There was a peak in the 70s, but then the number of papers went down with a small bump again only recently. On the second slide, you can see an article which are randomized controlled trial. There are very few of them, and still most of them are trial on some, which included some children with Kwashiorkor, but did not specifically target these children. As a result, there is little impact on current treatment, which is based on weak evidence. On the next slide, you can see the implication of all this. Most of our knowledge on Kwashiorkor is based on all observational studies. These have limits as method of exploration. The pathology in the 70s were not advanced as we have today. Also, observational studies are not effective in determining what is the cause and what is the consequence among all the anomalies which have been described. I think we need to address the balance and have more randomized clinical studies to improve current treatment. Randomized clinical trials, however, will help only if they are well designed and based on sound understanding of the pathophysiology. So we need to have a dialogue between those involved in study on pathophysiology and those who can run clinical trials. I think this webinar is an excellent opportunity to do that. And I wanted to congratulate those who proposed the idea and organized the whole seminar. So now I will call Alexandra Rutishauser-Perera, Head of Nutrition Action Against Hunger UK, Mary Fitzpatrick, Senior Researcher at the Feinstein National Center University, and Bryan Gonzales, who has been just appointed Professor at the Wageningen University in Poland. All of them have a very long experience on Kwashiorkor, and I look very much forward to hearing the presentation. Alexandra, you are the first on the list. Can you go ahead with your presentation? Thanks.
Yes, thanks, André. Always a little bit intimidating for me because I'm the only one among all those great names that is not a researcher. So I hope to just bring a little bit more of an operational aspect on this. And unfortunately, because of the core of my topic, you will see that we need to have these webinars because I will not have a lot of things to say about the differences in treatment in Kwashiorkor. Next slide. So talking about the diagnosis itself, so there is a WHO international classification of disease. The last one is from last year. And it does define Kwashiorkor as a form of severe malnutrition with nutritional edema, but also add with dyspigmentation of skin and hair. But there is an issue here with skin dyspigmentation because first it might be slight and remain unnoticed. And also hair changes often require a longer time to take place. So the definition that is actually mostly used in country, as well as in the 2013 WHO updated guideline on the management of SAM, only use edema in its simplest clinical sign. This is also the definition that is used by the Wellcome Trust, which introduced the term also marasmic Kwashiorkor for children with edema and a weight for height in this less than 60%. And this presence or not of edema and its severity determines several aspects of the treatment of children and where they will start their treatment. So we know that the WHO guidelines advises for only the children with generalized edema, or what we call 3 crosses edema, to be admitted directly as inpatient. The 1 cross and 2 cross could be admitted if they don't have any other complications directly as outpatient. However, it's something that often in national guidelines has been lost, and we can often see that even the children with 2 cross edemas are very often admitted as inpatient directly, which can potentially, we know, affect their access to treatment. Then the severity of edema will also determine changes of treatment phase. If the child is in inpatient, if the edema decreases, the child can progresses in the treatment. But if there is an increase of edema, then the child has to be demoted and potentially go back to the phase 1 if the child had been progressing before. And finally, also the presence and the severity of edema will determine the discharge, and also explains why it takes longer for Kwashiorkor children to be discharged, because we have to wait at least 2 weeks after the disappearance of the edema, while the other criteria of exit are also fulfilled, so that the children do not come back to the treatment. So next slide. Really what we see here, and this is going to be a theme really along the series of webinars, is that we are talking here, when we are talking about marasmus and Kwashiorkor, of two different diseases, but with two different pathophysiology mechanisms, but treated similarly. Next slide. And so in terms of the management and the treatment, as I just said, both marasmus and Kwashiorkor children are actually treated with the same nutritional products and are same medical treatment. The only differences that we see in some guidelines, and the last guidelines of MSF, Médecins Sans Frontières, that they published earlier this year, is actually probably the strongest one in identifying those slight variations. The first one is about dehydration. We know that skin turgor, for example, is not present, even when children that are Kwashiorkor are hypovolemic. And so it's a lot more difficult to diagnose it. We know it. We know it's already difficult to diagnose it in marasmus. But in Kwashiorkor, there is even these beliefs very often that Kwashiorkor children cannot be dehydrated. So the diagnostic of dehydration on those children is often missed and undertreated. And the only notion that you often see about Kwashiorkor children in the management of dehydration is that they require extra care and surveillance, but it doesn't go further than that. Where you can see bigger variations, and in the guidelines of MSF, you even have a dedicated part on the skin lesions. That's really where the management of the malnutrition is really, really specific to Kwashiorkor children. They often have dermatosis that are characterized by hypo or hyperpigmentation. There could be also desquamation, that flakes or peels. If you've seen Kwashiorkor children, or if you treat Kwashiorkor children before, you know exactly what I mean. And in extreme cases, those children can show ulcerations that may spread to any part of the body. The issue with those ulcerations is that it can lead to hypothermia and can be easily infected on children who we know do not exhibit a standard inflammatory infection. So where it's really, really difficult to know if the ulcerations are actually infected. And for that reasons, there is a recommendation for all Kwashiorkor patients, even the ones without skin lesions or wounds, to have skin hydration. And also, it's really advisable to group Kwashiorkor children all together to make sure that they don't get infections from other children that are marasmus. So MSF, once again, in their guidelines, have a table for dressing choice for Kwashiorkor skin lesions according to their moisture balance and infection status, which is extremely interesting. And there is current ongoing work to develop a scoring system for these lesions in Kwashiorkor children that will actually be presented in further webinars of this series. So really, again, you can see that not a lot of differences in terms of management, very slight ones. Next slide. Because we have a good opportunity right now to actually gather all the latest evidence on Kwashiorkor, because WHO is about to review their guidelines. We know it because they recently did a call for authors. So we are hoping that this series of webinars will really help. Thank you very much. I'll hand it over back to you, André.
Thank you, Alex. This is a very good start. The question will be at the end of the presentation. Now, Mary, can you give your presentation, please?
Thank you, André. And thanks to everyone for joining us here. It's really exciting to see so much interest in Kwashiorkor, to see this discussion on evidence moving forward. From the first recognition of Kwashiorkor as its own syndrome almost 90 years ago now, the role of diet's been debated in the etiology of Kwashiorkor. Recent reviews now often discount diets as a causal factor altogether. So it seemed appropriate as we started this series of webinars to review exactly what data about diet and Kwashiorkor is available, what it does say, and what it doesn't say. Next slide. So anyone who's tried to quantitatively measure diets of free living people, especially children, knows how difficult and resource intensive it is. One person's diet can vary day to day, week to week, seasons change, families' financial situations change, so the quantity of a serving can change. Intra-household access to food within the household, especially the more nutrient-dense foods, is different for different people in the family, and especially the young children. So extrapolating individual intake from household diets is also difficult. And where kwashiorkor is endemic, prevalence in the total population is often less than 3%. So that requires a large sample sizes for prospective studies. Studies on individuals may misclassify controls when they're working within a high-risk population. And to measure the diet of children leading up to the onset of kwashiorkor, we need to do something that's difficult, resource intensive, and repeatedly over a long period with a large sample size. So unless diet measurement is the central point of your study, there's few of us that are willing to do this. Most research on diets leading to kwashiorkor have resorted to creative, but maybe less than ideal alternatives. The risk is that they're not sensitive enough to real differences, and they're unable to distinguish between what's a real and a spurious relationship. Next slide. So as André pointed out, much of the reporting on kwashiorkor has been observational, especially in the earlier years. Gopalan's 1968 report at the first kwashiorkor colloquium in 1967 was among the first to try to measure nutrient intake of children with kwashiorkor. This is probably the most cited evidence we have related to kwashiorkor and diet, but it's also probably the most miscited article. Part of this is because it was difficult to find it in print before 1992. And by then, authors were depending on how previous authors had interpreted this article. So the article's cited almost conclusively as saying Gopalan did not find a difference in diets between cases of kwashiorkor and marasmus. But if we read the report really closely, and here's a quote from the report, there were no striking qualitative differences in the dietary pattern or in the protein-calorie ratio of diets between cases of marasmus and kwashiorkor. So he doesn't give dietary data on any comparison group separately, only on the global figures for the full population. But a few years later, Gupta conducted another study which provides actual data with statistical variation. And he found that children with kwashiorkor had eaten twice the calories, but significantly less protein than children with marasmus. Gopalan's article presents only qualitative conclusions and no data, but it's cited as clear evidence of an association with diet, as clear evidence of lack of association with diet. But Gupta's was more robust data is often ignored. Next slide. So recently, the more recent research has focused mostly on metabolic anomalies of kwashiorkor. So diet has kind of moved to a side issue. Rather than quantitative measures of diets, more recent studies have largely used food frequency questionnaires. And some of these have tried to calculate nutrient intakes from these. These studies did not find differences in dietary diversity, but they did find odd differences in food items, sometimes making assumptions about nutrient intake from those. But food frequency questionnaires were designed for assessing food security and general diet quality, rather than as a quantitative diet recall. Although there's some evidence for an association between food frequency and overall intake, it's too loose a relationship to be able to make conclusions on nutrient intake with any degree of certainty. Next slide. Next slide. Oh, yeah. So in in Fitzpatrick et al., my dissertation, we did a 24-hour quantitative recall of children's diets in neighboring high and low prevalence populations. This study found results very similar to Gupta's, with sufficient caloric intake, but borderline biologically available protein. But looking more closely at the protein, methionine was the limiting amino acid, and the higher prevalence population had higher risk of methionine deficiency. Another approach to investigating diets is to look at individual nutrients and classes of nutrients. Chilaverto and all provided a population with an antioxidant cocktail to see if this would prevent kwashiorkor, but it didn't. May et al. Conducted an RCT of mouse models and found that choline supplementation in a vegetable-based diet prevented steatosis of the liver. Next slide. So looking at what data we do have, the minimal data that we do have about diets, we can't make individual nutrient claims from food frequency questionnaires because portion sizes vary too much. What we need are prospective quantitative diet recalls, sensitive enough to calculate individual nutrients, but these are extremely rare due to the difficulty in conducting them. We need to move away from looking at total protein and toward individual nutrients, especially amino acids, and factors that affect their requirement. Considering the extremely limited robust dietary available, it might be too soon to discount diet as a major causal factor at this time. And back to you, André.
Thank you, Mary. Excellent presentation. Now, can I ask Brian, the last but not the least, to give his presentation?
Hi, thank you very much, André. It's an honor to be presented by you. But just a correction, I am a novice in Kwashiorkor research, of course, compared to my other panelists, and it's a privilege for me to be invited to be part of this. And I wish everyone greetings from Wageningen in the Netherlands, and I hope everyone is having a great day. So in my section, I would like to give a rundown on recent reports about the biochemical perspective on the pathophysiology of Kwashiorkor. Now, this is not an exhaustive list. There are several studies out there. But I would just like to first refer to Alexandra's point that despite some differences in these two phenotypes, studies often study them as one group and compare them to healthy controls. Other studies also study only Kwashiorkor versus control or marasmus versus control. Now, on a biochemical perspective, if we are to understand the pathophysiology of Kwashiorkor, we should be mindful of what makes it different from marasmus, and not only what makes it different from a healthy, non-malnourished child. Also, several studies compare a sick child or a child with complicated SAM versus a healthy control. And these kinds of studies are quite agnostic to whether the biochemical observation we see is because of the disease or rather than because of being Kwashiorkor. So next slide. The metabolism in Kwashiorkor has been reported to be different from that of marasmus, and one of the most striking difference is the reported fat deposition in Kwashiorkor, although there are some studies, in fact, there's one study saying that it's also observed in marasmus. And the presence of fatty liver strongly indicates that there is a metabolic perturbation. Now, I would like to highlight the magnificent work done by our colleagues in TMRU in Jamaica, who I hope we could invite to speak in our next sessions. Their studies are very good because they used kinetic studies, and using kinetic studies, they concluded that Kwashiorkor children are less adapted to conditions of nutrient deprivations compared to marasmus. Children with Kwashiorkor tend to have less protein synthesis and lower protein catabolism, and they also oxidize fat much less efficiently than those with marasmus. And our colleagues in Jamaica said that this can potentially explain why there is a higher risk for mortality among Kwashiorkor children than those of marasmus, because they are not adapted to malnutrition. However, we have to be mindful that conditions in Jamaica may be different from the clinical presentation and conditions of children in other regions, such as sub-Saharan Africa. So it's very interesting to study and perform these kinetic studies in different geographical regions. Also, we have a lot of reports about SAM in sub-Saharan Africa, and we have very low evidence in regions like Southeast Asia. I would just like to go back that the observation of protein catabolic inefficiency in Kwashiorkor, it has also been observed in children in Malawi. So maybe this protein metabolism problem is a global thing, it's a global occurrence. So we have to compare different populations when we study these metabolic disturbances. Next slide. Again, our colleagues in Jamaica have performed a very interesting study, which gives us an interesting perspective to the etiology of Kwashiorkor. They reported that children with Kwashiorkor tend to have higher birth weights than children with marasmus, which indicates a potential in utero nutritional reprogramming mechanism to malnutrition adaptation. It appears that children, especially those with marasmus, are programmed to anticipate a future malnutrition, and hence they are more easily able to adapt to a malnourished state than that of Kwashiorkor. Now, our group, in collaboration with KEMRI in Kenya, we used data from a longitudinal trial, and also we reviewed hospital readmission records in Kilifi, Kenya, and we found that once a children is admitted with Kwashiorkor, the child tends to relapse back to Kwashiorkor in case of relapse, and children with marasmus, they tend to relapse back to marasmus in case there is a relapse. So this observation also may support that malnutrition response could be predetermined rather than just a deprivation of a specific nutrient requirement. Next slide. The underlying mechanism, for this predisposition, of course, is something that we are not really sure of. It is very unclear. However, studies on DNA methylation and epigenetic changes that are reported in children in Malawi and in Jamaica indicate that there is a methylation pattern difference among children with Kwashiorkor, between children with Kwashiorkor and marasmus. And this hypomethylation of DNA that is observed in Kwashiorkor children is associated with one-carbon metabolism, such as methionine metabolism. An earlier study published by our colleagues in Jamaica, again, on muscle biopsies of survivors of SAM, noted differences in DNA methylation in Kwashiorkor compared to marasmus, especially those that are related to metabolic consequences. This, however, does not prove that DNA methylation causes Kwashiorkor, because these are observational studies, but this is a very good lead. And if we are to do further investigations, I think this is something that's very interesting to look at. In the next slide, more downstream metabolic perturbation can actually be observed if we compare the metabolome or the profile of metabolites present in biological fluids between the two phenotypes. Metabolomic studies comparing children with SAM and healthy controls, they all report differences in the metabolome profile, indicating that there is indeed metabolic perturbation in children with SAM in general. However, so far, I've only found 2 studies comparing marasmus and Kwashiorkor, and if any of you know of studies that compared the metabolome of both, please let me know. And interestingly, the results are a bit different. So when our colleagues from Toronto, Canada, performed targeted metabolomics in a population in Malawi, they found differences in Kwashiorkor versus marasmus. However, when an untargeted metabolomic study was performed in a population in Nigeria, these differences were no longer observed, and this is despite having similar sample sizes. So this only goes to show that if we are to demonstrate the role of metabolites and metabolic profiling in Kwashiorkor pathophysiology, we need more studies, and we probably need to compare different populations, again, in different geographical regions. Next slide. Of course, we'll be a bit remiss if we don't discuss about the role of gut microbiota when we discuss Kwashiorkor. And in fact, gut microbiome study has been a staple in any disease study, in any understanding of pathophysiology of diseases. And again, study comparing healthy controls versus SAM found major differences in their gut microbiome. And they reported that children with SAM have a deficient microbiome maturity compared to healthy controls. And apparently this maturity does not readily recover even after nutritional rehabilitation. However, focusing specifically on Kwashiorkor, a very famous and very highly cited paper by Smith et al. Showed that the microbiome has a causal link to Kwashiorkor development. However, I would like to again remind that in this study in particular, children with marasmus were not included in the study, and hence it is unclear whether the observed difference is specific to Kwashiorkor or is it something that is generally occurring in malnutrition in general. Also, the claim that the phenotype of the Kwashiorkor child was transferred to the mouse model needs further validation, as the study did not report edema in the mouse. This brings us a question of whether the mice really developed Kwashiorkor. And if it did not develop Kwashiorkor, was the phenotype really transferred? And if the phenotype was not transferred, is the claim of causality supported by the data? Again, these studies need to be conducted in different geographical regions, and I think this is a very interesting lead if we are to do more studies like this. Interestingly, a report in Uganda compared gut microbiome composition between Kwashiorkor and marasmus, and they did not find differences in both alpha and beta diversities. So I'm going back to the point that we need more studies. We need more studies in different geographical regions if we want to understand the role of gut microbiome in Kwashiorkor development. I would also like to add, I'll just breeze through that there are several papers suggesting that Kwashiorkor is caused by the lack or the loss of specific species of gut bacteria. But we have to further validate these claims. As in my personal opinion, the data is not very strong. Lastly, since we touched about animal models, in the next slide, since we touched about animal models, it is really worth asking ourselves, how do we define Kwashiorkor? And how do we define Kwashiorkor in an animal? We have to evaluate the face validity of these animal models. Most reports on Kwashiorkor do not report the presence of edema, but rather they focus on the development of fatty liver. So is this Kwashiorkor? Is this enough to say that the animal developed Kwashiorkor? And if not, are we extrapolate these results from the animals to what we observe in the children? And the next slide, in summary, I think, and I believe these are really exciting times to study Kwashiorkor because of the availability of technologies that we have now. And I'm looking forward to reading studies and collaborating with groups interested in using systems biology approaches to understand the pathophysiology of Kwashiorkor. And with that, I thank you for this opportunity, and I look forward to the discussion. And in the next slide, you will see the references that I have discussed. And with that, I give it back to André. Thank you very much.
Thank you, Brian. Very good presentation. Now I hand it over to you, Alexandra, to manage the Q&A session.
Thanks, André. So I've got a few questions already, so that's great. I'm going to dive in, but please continue to add your questions as you have them, because some answers might also provoke some thoughts. Hopefully, we will get to as many as we can, but I can't make any promises because we have actually 138 people attending the call. But please continue. So I actually have a first question for Mary. Mary, it's actually a question about protein. So how does our new emphasis and knowledge about protein quality rather than protein quantity change our thoughts? Should some of these studies be repeated with more emphasis on protein quality in addition to simply quantity? Thanks, Mary.
Okay, thank you. This is a really good question. So how does our new emphasis and knowledge about protein quality rather than protein quantity change our thoughts for that particular question? Really, there's two parts to that. You can have a lot of protein, but if it's not good quality protein, then the bioavailability of that, how much your body can really use of that protein, is limited. So the higher the quality of the protein, you can have small amounts of high quality protein, and it provide more benefit than large amounts of very low quality protein. We were talking about like methionine, and a lot of the diets that we look at are limiting in one amino acid. Say it could be lysine, it could be methionine. And if it's limiting in that one amino acid, that reduces the ability of your body to make proteins from the full. We're getting to understand more and more about the non-protein uses of amino acids. And I think that's really key. A lot of times the calculations on your requirements for specific amino acids are based on their protein functions, but a lot of them have non-protein functions. So like cysteine it's a key source for glutathione, which is then an antioxidant. And we say something we see a lot of in Kwashiorkor is oxidative damage and low levels of glutathione, which could be related to intake of sulfur amino acids. So should some of these studies be repeated with more emphasis on protein quality in addition to simply quantity? I don't know that you should repeat them, but maybe add to them. Definitely, when we do dietary studies, if we have a hypothesis that there is a relationship to a particular amino acid profile or a particular amino acid, then we do want to be able to measure that. If you're just looking at total protein, you could totally miss the real utility of that protein to a child. I'll stop there so we can have more questions.
Thanks a lot, Mary. I also have a question for Brian. Brian, the questions is about the terms actually, and I think you will appreciate the question because we've discussed it previously. So at country level, our colleagues say that they're highly discouraged to use the term Kwashiorkor marasmus, and I know that we're talking about East Africa here. And they rather talk about protein energy malnutrition, POM, with or without edema. So the question is there any study to explain further on the need to change the naming for the two conditions?
I'm happy that somebody raised this question. I think this should be answered by all of us, in fact. I do not have any strong opinion at it. I just think that we should have an agreement on how to call it. The problem with calling it, protein energy malnutrition is the fact that it might give the impression that this is a purely protein-related disease. On the other hand, if we call it edematous malnutrition, we are also only saying that this disease is only because of edema. So I believe we should indeed discuss how to call this disease, and I do not have any strong answer. I think I will refer to André. What do you think, André?
I have no strong opinion. I mean, the discussion started years ago because initially, Kwashiorkor, when you look at the old Bryan report, it could mean a lot of different clinical situations, and some of them with edema, some of them with no edema. So to standardize the whole thing, why this welcome group, they said that it was needed to have edema to get Kwashiorkor. But the result is that some children have only edema, as mentioned by Alexandra. So I don't think it's that important to use one or the other term. The most important is whatever you use, you clarify exactly what you mean by it. That's all for me.
Thanks, André. I'm having also an interesting discussion with a participant, and actually, which links to another question of a participant. So I'm gonna try something here because it's two questions in one plus a discussion. So somebody is asking if there is a research showing the performance of RUTF for Kwashiorkor or marasmus, and referring in terms of cured, length of stay, and relapse. And on the side, I was having a discussion. I think I can name him because he's famous and he's part of our group. So Indy Trehan was communicating with me. Sorry for naming you Indy, but you are bringing a lot to the conversation. So Indy was actually asking a provocative question, saying that perhaps it's marasmus that we really don't know how to treat to some degree. And while acknowledging that historically Kwash children have done worse, it just seems like that with RUTF in uncomplicated kids, we seem to be doing okay with Kwash related to marasmus. And he was naming two papers. One, and I'm struggling with my screen. One is from Southern Ethiopia in Woleta, treatment outcomes of severe acute malnutrition in children treated within outpatient therapeutic program. It's from Caballo and Seifu from 2017. And then, if I manage to open it, yes. There is the famous one. I'm just struggling a little bit with my screen because I opened the table. The famous one that is looking at antibiotics as part of the management of severe acute malnutrition, which is from 2013 from Trehan and all. So it's a bit of a question for all, but basically, this is what we seem to see, that Kwash children uncomplicated Kwash children seem to do better with RUTF than with marasmus. And so the question from Indy is, isn't it maybe marasmus that we don't really know how to treat? I'm going to ask that to André.
Thank you, Alexandra. That's a good point, because all the points I made about the lack of strong evidence regarding Kwashiorkor, I could make the same slides for marasmus as well. And the current protocol, they are based on the expert opinion from all studies, and we don't know whether they are optimal or not. I'm not sure about being easier to treat than Kwashiorkor, because usually when you look at the mortality data, the big edema is an additional risk factor for death. It's a bit complicated, this issue, because as you know that many places you assess nutritional status by weight for age or weight for height, and this assessment is not reliable when you have edema. But I think with the study we're using MUAC, which is not as strongly influenced as the edema, by edema as the other indices, I think edema comes up as a risk factor. So I think we need, it's not very clear to me, but I think marasmus is still, Kwashiorkor presence of edema is definitely a risk factor to me.
Thanks, André. I'm getting a lot of questions that are becoming very interesting. It's really hard to prioritize them, but I have a really good one. I think I will ask you, Mary, to answer that. But please, Bryan and André, if any of you has also an idea, jump in. The question is if there is any weight to the idea that soil quality may be a predictor of Kwashiorkor.
Okay. That kind of goes back to the nutrient content of foods. Different foods grown on different soils will have different nutrient contents. That's one of the difficulties of doing a good diet, a quantitative diet recall and calculating nutrient intake. They found that maize grown in different places has different levels of protein intake, different levels of protein. They have different levels of lysine in them. So yeah, soil quality can have an impact on the quality of foods. If people are getting their foods from the markets and it's a mix from a large number of different places, then it's less likely to be having an impact on the population. But if the population is largely subsistence and they're depending on their food grown locally, that could have an impact on the quality of the diet from the person. Does anybody else have something to add to that?
One of the problems in comparing area with different soil quality is that in epidemiology you learn that comparing occurrence of a disease between different areas is one of the weakest evidence you can get to draw causality, because there are so many differences which can occur between different regions. So I think it's an interesting idea, but it's difficult to establish that very firmly. What we can say, and this was shown years ago, is that prevalent Kwashiorkor does not occur everywhere. In Africa, it's really concentrated near the equator. And this was confirmed by the study that Alexandra referred to by Jose Luis Gonzales. We found again, main area of Kwashiorkor in places where in the middle of Central Africa. And usually it's places where people eat maize or cassava. But there are so many, these foods are different in so many aspects that it's very difficult to point out exactly which is the problem.
Right. So that points back to when we are gathering data and when we are doing a study, we need to gather as much information as we can on as many variables as you can. So if a population is eating food that's locally produced mostly, noting that if you're calculating nutrient intake, then actually analyzing the foods that are eaten locally, because like we said, maize produced in one place may be different than a maize in another. And if you're trying to find out the metabolic differences it's having in a body, then you need to know what is the actual nutrient content of their food, because it can vary by soil and by other factors, climate and variety.
Thanks. Thanks a lot. I'm going to have another question for you, Mary. So you say that in one of your slides that most dietary research focused on individuals, not on populations. Can you explain why you think this is a problem?
I don't know that it's a problem necessarily, but it's an opportunity that we need to check. It's like we see with stunting. You see that in a community where stunting had a high prevalence of stunting, it's not just that there are certain children that are affected, and so you have a left tail on the distribution curve. Instead, what you see is the whole distribution curve shifts downward. If Kwashiorkor is we find Kwashiorkor clustered. And if you're in a cluster, if you're taking your cases and your controls from the same community, you may be misclassifying children. If the whole curve is affected, if the whole population is affected, but only some are more affected than others, and those are the ones that fall below the threshold, you may be comparing severely affected children with less affected children rather than comparing severely affected children with unaffected children. And that could lead to misclassifying and making your study less sensitive to detecting these differences. If we have two populations that are nearby, one has a high incidence and one has a low incidence. This is how scurvy, beriberi, pellagra, a lot of different dietary deficiencies, that's how you really gain some insights, was by comparing, okay, this population has a lot of it and this population has a little bit of it. Like André was saying, there are a lot of confounding factors in that. But if you can choose populations that are as similar as possible, except for certain factors, then you can see are those factors associated. And these are observational, they're not causational, but they can give us a lot of insights that can be lost just looking at cases.
Hi, can I just, yeah, I'm lucky I'm one of the panelists, so I could raise my question directly. But with regard to the regional distributions, how do we, when there's a region with high burden of Kwashiorkor, how do we see the burden of marasmus in that same region? Because how are we sure then that what we observe is specifically a Kwashiorkor problem, or maybe the SAM burden in that population is generally low, and what we observe is probably related to SAM in general and not to Kwashiorkor specifically?
Well, we'd have to choose our populations carefully when we do our studies. There are populations that have very low wasting and yet significant levels of Kwashiorkor. So a population like that would naturally account for the lack of the effect of the Kwashiorkor. So each of these, we kind of have to choose our populations very carefully to naturally control for as much as possible.
If I may, if you go back to the paper by Jose Luis Alvarez, you can see that there's huge variation from place to place in the ratio edematous malnutrition, which means that this variation you cannot explain that just by the difference of occurrence of SAM. I mean, there's definitely places we have Kwashiorkor and definitely places where children go predominantly to marasmus.
And I think one thing that's key in these, when you talk to these populations, these have long-term trends to them. So there are certain populations that have long-term trends of, say, Kwashiorkor and marasmus mixed, long-term trends of a higher proportion of Kwashiorkor to marasmus or marasmus to Kwashiorkor. And so they have some long-term trends with that. But it does vary considerably by area, as André said.
Yeah, I would just like to highlight what Jay Berkeley has sent. I think this is a private message to me, but yeah, he's suggesting that studies over time would be the most powerful in high burden areas, and I really think this is very true. And my dream is that we could potentially collect, let's say, urine or by any sample that we could test, because a specific deficiency of a nutrient can be tested using the technologies we have available. We have already validated biomarkers of specific deficiencies. So that would be very interesting if we could indeed study this over time. From when the child is born until any development of Kwashiorkor in a specific high burden area.
Yeah, that would be ideal, definitely.
Yeah, thanks, Brian. And I think it's as André explained at the beginning, like there was a boost of research on Kwashiorkor at the time when the technology was not there. And now the technology is there, so maybe time for another push. I have potentially, I think, time for 2 more questions. So I'm going to have one for André. So André, you said that very few randomized controlled trials were made for Kwashiorkor, and that current treatment is mainly based on expert opinion. From the few available clinical trials that are available, how many of these clinical trials do you think had an influence on the current recommendations for treatment and prevention? And I think this question gathers also questions that others have asked. So I thought that was a really good one.
Thanks, Alexandra. I think existing randomized control trial had a limited impact for different reasons. So first, some of the non-clinical outcome, for instance, glutathione synthesis after supplementation with cysteine, or protein synthesis after supplementation with aromatic amino acid. So these are very important studies for understanding edematous malnutrition, but they have no direct clinical impact on treatment. Some study had a clinical outcome, but they failed to show an impact, and such as the use of mineral and vitamin antioxidant mix that you refer to, Mary, which had no impact on programs. Some study had an impact, but surprisingly, this did not change. This did not lead to a change in practice. So a trial showed years ago that supplementation with reduced glutathione or alpha-lipoic acid or N-acetylcysteine resulted in lower mortality in dermatous malnutrition. Surprisingly, this was never confirmed, and the current antioxidant mix used in F5 to treat Kwashiorkor does not contain the specific antioxidant. To my knowledge, the only one trial and an impact on current recommendation. It tested the effect of a high dose of vitamin A on outcome of SAM and found an increased mortality in edematous children. This led WHO to drop the recommendation of giving a high dose of vitamin A on admission for children with edema. So again, the current treatment expert opinion with a low level of evidence. This doesn't mean that the current treatment doesn't work. I mean, the expert made the recommendation based on clinical experience with many trials and error, but relying on expert opinion for disease that we do not understand really and for which there are different interpretation is not a really comfortable situation. Thanks.
Thanks a lot, André. And I think to finish, I will take the last one. I've been asked that there were several questions or comments about the donors' interest on Kwashiorkor, and then is it really a domain that that donors are looking at? On our understanding, not yet. Which is exactly why we have invited them to this webinar series, hoping to raise some interest and questions. There is a link to that, a question on the research priorities that we should be focusing on in Kwash. So actually, one of the main goals of the Kwash webinar series is exactly about gathering what's out there and evaluating what are the gaps and having these discussions and the questions that that we are having right now to identify more priorities that we should be having and research that should be designed for Kwashiorkor. So at the end of the 3 webinars that we planned, the Kwashiorkor working group will actually meet for a synthesis. However, I can mention some areas that are already identified from the document putting Kwashiorkor on the map that we referred to several times. So there is one, and we touched upon it, about examining the mortality risk of children with edema, marasmus, and marasmic Kwashiorkor, which is something we discussed. Examine the geographical distribution of potential causal factors, and this is once again something that was discussed a little bit today. The importance of measuring incidence rather than prevalence, as well as the duration of each episode of edema and different treatment-seeking behaviors that deserve further investigation. So that's just some already ideas about research prioritization, but really we are hoping this series of webinar to help us highlight more of them. So we are just about out of time, so I will wrap up. Can you change the slide, please? Thank you. We have 2 webinars coming up that will look at different aspects of Kwashiorkor. We will update you on the dates later on. So to stay involved and hear more about the following 2 Kwashiorkor webinars, if you found this one interesting, follow the Feinstein International Center's Twitter or join the e-list. The information for this is on the bottom of these slides. And then next slide. So if you had questions that did not get to, or if you needed a little bit more time for questions to raise, or if you are listening to this recording and you were not live and you have questions coming up after, please send them to the person you would like to address it to. Mostly to me, as again, if you want some very technical research answers, I might not be the right one. But if you want to know about joining the informal Kwashiorkor working group because you are actually working on research, or you had working on research on Kwashiorkor, please send me an email. As a follow-up, we will share the webinar recording with you in the next couple of days, so you will all have it. When you leave the webinar, a very short survey will pop up. Please do us a favor and take 30 seconds to answer the one question. This concludes our webinar for today. Thank you a lot for your active participation on the side. We were too many for you to be able to talk, and goodbye.
Bye-bye. Thank
And
you,
thanks
Alexandra.
a lot to our panelists.
Thanks a lot.
Thanks, everybody.
Thank you, everyone.